So last year, I spoke about incretins in the specific context of cancer chemoprevention. And that still is very much a field that's active. But of course, if you live in the real world, you are probably surrounded, not just in your medical practice, but overall by talk, chatter, social media, you name it, related to incretins. Now, much of the noise related to compounded incretins that were being purchased by the public should have by now faded away because, as you may or may not know, in April 2025, the Trump administration declared that the shortage on incretins in the US has now been abated and that no one should be selling compounded incretin. But you can still buy semaglutide and tirzepatide primarily from the same people that sold it to you before, except now it gets shipped from Mexico or Canada. So it still happens, except it comes from a different source. Incretin, of course, is a made-up word. Incretin stands for intestinal secretion of insulin. This was a term that was coined a long time ago in 1932, and the definition, which I'll spare you, reflects remarkably well what incretins exactly do, which is basically stimulating a decrease in blood glucose after eating by producing more insulin from the islets of Langerhans. Incretins are not just GLPs. I hate when people conflate the two. In fact, they have multiple targets. GLP-1 is typically the backbone, but GIP and glucagon are two other targets, and those in turn can impact the patient in a very pleiotropic manner and can actually lead to a number of potential benefits. Many people think that the benefit in terms of weight loss from incretins is primarily because of the development of side effects. Of course, not true. Incretins act primarily through the mesolimbic system in the brain and suppress appetite and promote satiety. In fact, people who have no side effects from incretins, which those people do exist, tend to lose more weight than those who get GI side effects, probably because they stay on therapy longer. More on that in a second. So why is everybody interested in incretins? Not because they improve your cardiometabolic risk and make you live longer. By the way, they probably do. Everybody's interested in losing weight. And this is one exemplar of many of a drug called tirzepatide, which basically here in a series of studies summarized here by one paper in the New England Journal, basically results in profound weight loss at not only 52 weeks, but well beyond in a plateau manner all the way out to 163 weeks. Why am I showing you this? Because if you stop tirzepatide within 30 weeks, you basically regain a very, very big percentage of the weight you lost. And so it has become pretty clear that once on an incretin for weight loss, always on an incretin. This is indefinite therapy. This is not likely therapy that has a clear endpoint. Some of the ramifications of incretins infiltrating the US population may have had something to do with this most recent set of data from NHANES. NHANES, as you know, is a congressionally mandated survey of the non-institutionalized US population. So excludes prisoners, excludes people who are institutionalized for whatever setting, and excludes the military. But it's supposed to actually have a fairly accurate reflection of Americans in general. And for the first time in about 50 years, obesity is actually either plateauing or declining. You would be left under the impression, if you looked around, that obesity is a rudderless ship that's basically progressing without any safeguards. That is not true. Now, this drop in obesity levels is occurring much more steeply in college-educated persons and in persons age 20, among US adults aged 20 and older, and that may be a byproduct of access to healthcare and other things. At the same time, there is a poll conducted by JAMA, the JAMA Commission, that indicates that roughly 12% of adults have actually used the GLP-1 drug in some form. It is thought that most of that is actually compounded GLP-1 that people purchased, not actually prescribed GLP-1. Of course, seems like something that a lot of patients would get into, but there is no yin without a yang. And here, obviously, a major downside is side effects. This is also a breakdown from the SURMOUNT-3 trial, the same trial of tirzepatide that I showed you earlier that showed weight loss. And if you actually look at this, it's really not that bad. Discontinuation due to AEs, 1.6% and 1%. Discontinuation due to from study drug due to AEs, 3.8% and 4.5%, and even at the highest dose, 7%. That's not too bad, right? You would think that that would actually work out for most patients. But in fact, incretin discontinuation, it turns out, is much greater. This is an analysis of a large database that primarily revolves around claims by Zeke Emanuel. If you know who Zeke Emanuel is, the guy who supposedly wrote the Affordable Care Act, who now, I guess, focuses all his time and energy looking at access to incretins. That's pretty much what he does for a living. And so if you actually look at incretin discontinuation, it actually makes a big difference while you're on an incretin. If you are on an incretin for diabetes, you're much more likely to stay on it, although your discontinuation rate at 1 year is about 46%. If you're taking this for weight loss, it's sort of a zero-sum game if you end up not losing weight, and therefore you stop taking it 65% of the time at 1 year. And of course, reinitiation follows a very similar course. 34% of people without type 2 diabetes reinitiate versus 51% with type 2 diabetes. I suspect that these numbers are too high and probably reflect more the way claims are actually being made as opposed to how many patients stop and start. But what is clear is that discontinuation of incretins is not 6% and 7%, probably flirts with 20 to 25% as the best estimate. There's, of course, another downside to incretins, which is that both tirzepatide and semaglutide, and by the way, every other incretin, including liraglutide, exenatide, which we don't use, dulaglutide, you name it, has a black box warning for not taking if you have a thyroid C-cell tumor, such as medullary thyroid cancer or MEN2A. So that is a hypothetical concern based on the mechanism of action of the drug that the agency many years ago put in the label for all these drugs. In fact, we have data that suggests that thyroid cancer incidence among people who take a GLP-1 versus another class of anti-diabetic drugs called DPP-4s is really not that different. These are data published in the British Medical Journal last year. These, believe it or not, include every single patient in the country of Denmark that actually took an incretin or a GLP-1, and you will see that the cumulative incidence of thyroid cancer is pretty much almost exactly overlapping between the two. So there is not an overwhelming set of evidence beyond the hypothetical that these drugs may increase your risk of thyroid cancer. Back to a more positive aspect of this, I mentioned last year that there is now definitive data that suggests that these drugs help with a variety of liver diseases, including most importantly and prominently MASH. In fact, an FDA-approved indication of one of these drugs, semaglutide for MASH, was just happened 3 weeks ago. But there's also perhaps downstream from this an implication that GLP-1 receptor agonists and perhaps dual agonists like GLP-1s, GIPs may actually reduce your risk of HCC and may also reduce decompensation primarily in the setting of diabetes. This is a paper from the late Nate Berger from the Center of Society and Medicine before Nate passed away last year, probably his last paper, and it shows actually quite convincingly based on an analysis of TriNet. I don't know if anybody's familiar with TriNet, but that's a large database made also primarily of claims that this is indeed the case. And I showed this last year, I'll show it again. There have since been 3 other studies that essentially shows that 3 other meta-analyses, I should say, that show the same. That if you look at the 13 so-called obesity-associated cancers, with perhaps the exception of thyroid cancer, there is a clear trend towards reduction in incidence of these cancers at a 12-year follow-up. This is about 1.6 million people when you are on a GLP-1 agonist versus when you are not. This is actually a subset of patients who are taking insulin or not insulin, but I can show you the same data for other classes of anti-diabetic drugs. The last point I want to talk about today, and it looks like I'm going to finish on time, which is amazing, is cancer cachexia. So cancer cachexia is something that this audience is very familiar with. As you know, it is a systemic disease driven by the tumor, though not exclusively affected, though not exclusively in the case of many patients. Tumors, of course, secrete a variety of inflammatory agents, including TNF-alpha, which is sort of traditionally thought to be the agent that drives cachexia, but also a variety of interleukins, IL-6 probably the one most commonly mentioned. And these have profound effects on a number of different end organs, including adipose tissue. I did not know this until recently, but TNF-alpha actually causes browning of white adipose tissue, which basically turns adipose tissue into a more metabolically active type of fat. The irony is that your patient who has cancer actually is more efficient at metabolizing fat than the patient who does not, which is the last thing that patient needs. There's also, of course, muscle wasting, which in turn has some downstream implications, and there is probably a number of effects on both satiety mechanisms, a dysbiosis in gut microbiome, and the immune system. And in fact, when you give an incretin to a patient, you do not only make them lose fat. Wouldn't that be wonderful if you took medication and every pound or kilo that you lost was actually fat mass? You lose a significant amount of lean body mass. And this is a summary of a number of different agents. Some we don't use very often, and some we use every day, including tirzepatide and semaglutide. And to sum this up, I would say that from liraglutide, which we rarely use, all the way to high doses of semaglutide and tirzepatide, you're losing somewhere between 36 to up to 20% of your lean body mass. The proportion of weight you lose is somewhere between 36 to 20% of your lean body mass in proportion to total weight. So this is obviously not good in cancer, right? The last thing you want to do is rob patients who have cancer of their lean body mass and enter bimagrumab. Bimagrumab is an agent that was initially tried for spinal atrophy and Duchenne muscular dystrophy. Didn't work out for either, and was repurposed by a company called Versanis to study it as a muscle-sparing agent in the setting of incretins. It is an activin type 2 receptor. It's actually an activin type 2B receptor agonist. It's a monoclonal antibody, and the BELIEF study, which is the pivotal study that was supposed to show us whether this indeed is worth its weight or not, was just published in JAMA 2 months ago. This monoclonal antibody has targets on both adipose tissue and muscle, and essentially alters muscle homeostasis in a way that makes it less likely to resorb over time. It is administered currently quarterly through an infusion, but there are plans now that Lilly has acquired Versanis to actually turn it into a subcutaneous weekly injection, which would coincide exactly with how you give an incretin. And in fact, this is the summary of the BELIEF trial published in JAMA, presented at the ADA meeting this year by Steve Heimsfield. And what it shows is that in this 507 patient study, and you'll have to humor me from left to right, you have placebo on the left, and on the right you have semaglutide at the highest dose. That is the Wegovy 2.4 milligram dose. For those who are familiar with high dose bimagrumab, you actually have not only potential preservation of muscle mass, but compared to arms that do not have bimagrumab, where you lose 28 and 29% of your lean body mass as a percentage of your total body weight, you have significant preservation of this. And in fact, even at the highest dose, 93% of the weight that you now lose is actually fat mass, and only 7% is lean body mass. Interestingly, in patients who do not take an incretin, who just get bimagrumab, there is actually retention of your lean body mass. And in another study, which I don't have the time to show you, you may actually accrue body mass. So there are other lean body mass. There are other studies looking at cancer cachexia and looking at other muscle atrophy syndromes that may be coming after this. Before I conclude, why should you care about this? Why did you listen? Why did you spend 10 minutes listening about this? It actually doesn't matter whether you end up ever prescribing an incretin to a patient or managing incretins. Whether you like it or not, at the rate at which things are going, you are going to have a large number of patients who are on an incretin. This is a back of the envelope calculation that I made. This is a very conservative estimate, by the way, based on today's FDA-approved indications. There are 6 of them. And if you actually just factor these alone, as of next year, 40 to 50% of all humans in the United States have an FDA-approved indication for an incretin. 40 to 50%. Coming soon, HFpEF, right? Heart failure with preserved ejection fraction, the 3rd most common cause of hospitalization of people in the United States. PCOS, a very common disease, probably 8% of women have some form of PCOS. Alcohol use disorder, no drug has been shown to have the same magnitude of reduction in recidivism as what we have seen so far in the tirzepatide trials, and osteoarthritis of the knee, which is actually going to be a very forthcoming indication probably in 2026. So I suspect that by 2035, 70% of Americans will have an FDA-approved indication for an incretin. So you choose to ignore that at your own peril. I think this is clearly going to be a major issue that is going to we have to contend with no matter what specialty we're in. So to sum up, we live in the incretin world. It's about to get worse or better, depending on how you think about it. The majority of Americans, I suspect, will have an FDA-approved approved indication for an incretin soon. We already have an FDA approval for MASH, and we have probably better treatments coming in the next, certainly 3 years. Incretins certainly seem to be favorably predisposed to be a cancer chemopreventive agent. We will see about that in the next few years. And last but not least, this is probably not just related to weight loss. It's related, of course, to reduction in cardiometabolic risk, but also reduction in inflammation and fibrosis. And I'm going to stop here, and thank you very much for your attention.